Hello all. Today's focus is going to be on fluids and electrolytes in the pediatric population. I'm sure you've all learned and discussed fluid and electrolytes in your previous clinical or pathophysiology courses, but my main focus is going to talk about the differences or unique items that are specific to the pediatric population and why knowing and focusing on fluid and electrolyte regulation is so important. So you recently learned that codes in the pediatric population are often respiratory related. Well, the other most common type of pediatric code comes from hypovolemic shock, or shock resulting from excessive intravascular fluid loss or hemorrhage. The most common cause of this type of shock worldwide is diarrhea or vomiting secondary to GI illnesses. As nurses, we are at the forefront of our patient care. We share both the challenges of illness and the joys of successful recoveries from our patients. In one day as a nurse, we may feel a multitude of emotions. Now, the video I'm going to show you is pretty heavy, but it helps convey one family's experience at a hospital and really hones in on how fragile the pediatric population is to work with and why it is so important to understand fluid and electrolyte relation.
My daughter Josie died a year and a half ago at Johns Hopkins due to medical errors. Not only do I represent Josie, but I also represent all of the other children, the mothers, the fathers, the sisters, the brothers, the 98,000 people who die every year in this country from medical errors. I'm here for them, for their families, and for any future potential victims. I would like to share my story with you. I do this with the hope that what I'm about to tell you will make a difference in how you care for your patients and how strongly committed you and your hospital are to patient safety. Josie was 18 months old. She had brown eyes and light brown hair. She loved to dance and had just learned to bounce on the trampoline with her older siblings, Jack, Relly, and Eva. She had just learned to say, "I love you." In January of 2001, Josie was admitted to Johns Hopkins after suffering first and second degree burns from climbing into a hot bath. She healed well and within weeks was scheduled for release. 2 days before she was to return home, she died of severe dehydration and misused narcotics. Her central line had been taken out. I began noticing that every time she saw a drink, she would scream for it, and I thought this was strange. I was told not to let her drink. While a nurse and I gave her a bath, she sucked furiously on a washcloth. As I put her to bed, I noticed that her eyes were rolling back in her head. Although I asked the nurse to call the doctor, she reassured me that oftentimes children did this and her vitals were fine. I told her Josie had never done this and perhaps another nurse could look at her. After yet another reassurance from another nurse that everything was fine, I was told that it was okay for me to sleep at home. I called to check in 2 times during the night and returned to the hospital at 5:30 in the morning. I took one look at Josie and demanded that a doctor come at once. She was not fine. Josie's medical team arrived and administered 2 shots of Narcan. I asked if she could have something to drink. The request was approved, and Josie gulped down nearly a liter of juice. Verbal orders were issued for there to be no narcotics given. Meanwhile, Josie started perking up. She was more alert and had kept all the liquids down. I was still scared and asked her doctors to please stay close by. At 1 o'clock, the nurse walked over with a syringe of methadone. Alarmed, I told her there had been an order for no narcotics. She said the orders had been changed and administered the drug. Josie's heart stopped as I was rubbing her feet. Her eyes were fixed and I screamed for help. I stood helpless as a crowd of doctors and nurses came running into her room. I was ushered into a small room with a chaplain. The next time I saw Josie, she had been moved back up to the PICU. Doctors and nurses were standing around her bed. No one seemed to want to look at me. She was hooked up to many machines and her leg was black and blue. I looked into their faces and said to them, "You did this to her, now you must fix her." I was told to pray. 2 days later, Jack, Relly, and Eva were brought to the hospital to kiss their beloved Josie goodbye. Josie was taken off of life support. She died in our arms on a snowy night in what's considered to be one of the best hospitals in the world. Our lives were shattered and changed forever. Josie died from severe dehydration and misused narcotics. Careless human errors. Josie's death was not the fault of one doctor or one nurse or one misplaced decimal point. It was the result of a total breakdown in the system. It was the result of a complete lack of communication between the different teams. It was the result of doctors and nurses not listening to a concerned parent. It was the result of a combination of many errors, all of which were avoidable. What if the nurse had called the doctor when Josie's eyes were rolling back in her head? What if she could have had a drink or had been hooked up to an IV? What if the residents had paid attention and seen that her weight had dropped over 15% in 24 hours? What if the nurse had not given her the methadone? What if someone had taken my concerns seriously? What if a patient safety program had been in place? I believe that if any one of these things had occurred, the outcome could have been different and Josie would be here today.
Okay, so I want you to take a minute and think about your initial reactions to that story. Now, we can spend a whole day talking about all that went on in that video, but the main reason I include this into this lecture is that a child died from dehydration in a renowned hospital, a hospital with resources and an excellent reputation. A child died of dehydration while being closely monitored. And so I want you to kind of think about that as I go through this lecture so that you can understand the importance of hydration, okay? So as I go through this presentation, we're going to focus on that importance and why we are so specific when it comes to accurately measuring, assessing, and recording the patient's I's and O's. As a nurse, we play such an integral part in patient care. We are the eyes, the ears, and the voices of our patients. We're going to review the distribution of body fluid quickly because water is important in body function, not only because it makes up a large portion of the body, but it also provides a place for the body solutes to be dissolved and metabolic reactions can take place. When talking about total body water and the distribution of body fluids, we're referring to intracellular fluid, or the fluid contained within the cells, and the extracellular fluid, or the fluid outside the cells, which is further broken down into intravascular, or fluid contained within the blood vessels, interstitial, or the area surrounding the cell, which is the location of most extracellular fluid, and transcellular, which is contained within specialized body cavities such as your CSF, synovial, and pleural fluids. Another thing to keep in mind when thinking about distribution of water and water balance. Under normal conditions, the amount of water ingested closely approximates the amount of urine excreted in a 24-hour period. Also, water in food and from oxidation closely approximates the amount lost in feces and through evaporation. So how do we maintain balance? Well, we need to replace that which is lost by insensible loss such as sweating, as well as urine and stool. There are situations and conditions that may increase water requirements, and you can see those here. And this is why we encourage hydration when sick. And there are also situations that may decrease requirements, such as heart failure, increased intracranial pressure, and renal failure. So you've already covered regulatory mechanisms in pathophysiology, but it's important to review these regulatory or internal control mechanisms and their influence on fluid and electrolyte balance. So they're trying to maintain equilibrium of that water and sodium balance, right? So if things aren't balanced, depending on what's going on, these hormone systems are activated. So we're going to briefly review the thirst mechanism and the roles that antidiuretic hormone, aldosterone, and the renin-angiotensin system play. All right, so this boy, he looks thirsty, right? He's looking very seriously at that water fountain that looks very dry. He's clearly sweating, his cheeks are red. So let's talk about what thirst is. It is a feeling or impulse to ingest water. It's pretty simple. It's stimulated by increased solute concentration or SALT of extracellular fluid and or by decreased circulatory or intravascular volume of the ECF. So some fancy stuff happens in the hypothalamic thirst center, which creates the feeling that we know of as thirst. The same mechanism takes place with infants, right? But how would they resolve thirst? They're not going to be able to say, hey, I'm thirsty, let me grab a tall glass of water. They depend on their caregivers to meet their needs. So again, it's important to pay attention to cues and make sure that they are adequately hydrated. So antidiuretic hormone, or ADH, is released by the posterior pituitary gland and responds to the increased osmolarity and decreased volume of intravascular fluid. It helps conserve body water by reducing the loss of water in your urine or helps hold on to urine. So this promotes water retention in the kidneys by increasing permeability of the renal tubules to water. So just remember that H is holding on and helping the body hold on to that urine, so otherwise known as water retention. Now, you may see patients in the hospital experiencing SIADH, or syndrome of inappropriate antidiuretic hormone. This is when the body's making too much. So you can remember this if you're having a hard time by recalling that C is yes in Spanish. So C, ADH, yes to ADH. This causes fluid retention, decreased sodium, or decreased osmolarity, and signs of symptoms of overhydration, okay? SIADH tends to occur in people with heart failure or with a brain injury that affects the hypothalamus. The immediate management of choice here is fluid restriction. You're going to see signs and symptoms of volume overload, such as bounding pulses, increased blood pressure, headache from all that fluid. They may have edema, have really dark brown concentrated urine. The underlying cause here needs to be treated in order to resolve the SIADH. Another hormone that plays an integral role is aldosterone, and this is secreted by the adrenal cortex and basically controls the mechanism for reabsorbing sodium in the distal nephron, which in turn promotes the reabsorption of water. It concurrently spits out potassium through the urine, and this results in increased blood pressure. The last regulatory mechanism we will briefly review is the RAS. This system helps regulate blood pressure, increase blood volume, and increase systemic vascular resistance. The stimulus for this is a decrease in blood pressure and blood volume or low serum sodium, because when low sodium exists, there is low fluid. Renin will convert to angiotensinogen, which is produced in the liver, to the hormone angiotensin 1, an enzyme known as ACE, or angiotensin converting enzyme, that is found in the lungs, metabolizes that angiotensin 1 into angiotensin 2, and angiotensin 2 causes blood vessels to constrict and blood pressure to increase. So just keep these systems in mind as we move on to talking about GI and GU disorders. Now, we've established that fluid and electrolyte balance is important, but how do infants and children differ from adults? Well, some issues that you are going to encounter are that fluid and electrolyte imbalances are occurring more often and more quickly. Children don't adjust as fast to these alterations in fluid balance because their kidneys are immature and they're not as efficient. They also require greater fluid intake and output relative to their size. They have a larger body surface area in relation to mass of active tissue, or greater body surface area per kilo of body weight compared to adults, and this predisposes them to greater insensible losses, especially through skin. As we've already reviewed, their respiratory and metabolic rates are higher, so they can dehydrate rapidly. So infants have a larger amount of total body water per unit of weight, so they naturally have a higher fluid requirement. They turn over about half of their actual cellular fluid daily, whereas adults turn about 1/6 or so over. And so this daily exchange really results in very little reserves for dehydration. Small alterations can cause severe physiologic consequences, especially in infants and children, because they have this large proportional difference. Also, in infants, the largest proportion of body water is contained in that extracellular fluid compartment, and in time as they grow, this will shift to being more intracellular and the total body water will decrease over time. We've talked about body surface area, and it predisposes the infant to more fluid loss, but what does it tell us? Well, body surface area tells us the total surface area of the human body, and it's used in a lot of measurements and is the most accurate way to calculate medication dosages and fluids to be administered IV, but we do often use weight instead of BSA, but we could use this for meds that have a very narrow therapeutic index like chemotherapy. So you may never use it, but it's important to be aware of and to understand how to calculate it. You're also going to see for premature infants that their body surface area is actually 5 times greater than an adult, and a newborn is about 2 to 3 times greater. And then we have your renal differences in infants and children. Kidneys are immature for the first 2 years, so they're inefficient at excreting waste products of metabolism like water, electrolytes, and uric acid. They have limited ability to concentrate or dilute the urine, to conserve or excrete sodium, and to acidify the urine. So that means they're more likely to become dehydrated when given concentrated formulas, or overhydrated when given excessive free water, or dilute formula because they're less able to handle the large quantities of solute-free water. This is why we do not give children under the age of 1 water, right? Because they cannot process it. And this is where water toxicity comes into play. All right, so this ends the fluid review portion of the presentation.